So now it's my great pleasure indeed and a real honour to introduce Professor Vikram Patel. Vikram is a diving enthusiast who has developed a great interest in the waters off the western Papua New Guinea. And he's also the author of the book Where There Is No Psychiatrist, that's well known to many people, or probably to most in the audience. So that in itself, those are two very good reasons to welcome him here. But he's Professor of International Mental Health and Wellcome Trust Senior Research Fellow in Clinical Science at the London School of Hygiene and Tropical Medicine in the UK. He was Joint Director of the school's Centre for Global Mental Health, and he's Honorary Director of the Public Health Foundation of India's Centre for the Control of Chronic Conditions. He's co-founder of Sangath. A number of you will have heard quite a bit about Sangath yesterday. It's a community-based non-government organisation in India. He's been honoured to be a member of the UK's Academy of Medical Sciences, serves on the WHO's Expert Advisory Group for Mental Health and the Mental Health Policy Group of the Government of India. And he was recently awarded in 2014 the Sangath International Prize from the Institute of Medicine in the USA. So Vikram, we welcome you to speak to us please about innovations in improving access for care to care for mental disorders in low and middle income countries.
Good morning and thank you. I think my talk follows very nicely on from Harvey's talk on why we need to take action for mental health problems around the world. We've heard from Harvey about the huge and rising burden. In fact, he didn't mention much about the rising burden, but of course, if he had time, he would have told us a little bit about more about, in fact, the proportionate burden of mental disorders that is rising in all countries of the world. Now, I wanted to first of all just say there's a slight change in the title of my talk, as you'll notice on this slide. What I want to do today, this morning, is not only give you a window into some of the exciting innovations that are happening in how we can address some of the burden of mental health problems in some of the poorest and least resourced countries of the world, but also perhaps to provoke us into thinking about what I call addressing the credibility gap. I think this is an even bigger challenge in my mind, which is the gap between how professionals view mental health problems and understand mental health problems and how pretty much the rest of the world understands these problems. Now, I'm going to request my colleague here that if I'm going too fast, just slow me down, because I know everyone in my family thinks I speak too fast. It's a particular pleasure for me to be also here in Cairns after 23 years. This is my second visit in Cairns. The first time was 23 years ago when my wife and I used to live in Sydney and work at the Westmead Hospital, where I first came face to face with issues to do with Aboriginal mental health in this country. And we did, of course, the traditional long walkabout through the heart of Australia for 3 months in a ramshackle four-wheel drive, and landed up in Cairns in 1992. And here is the evidence of that. I got my diving license here. For those of you with an acute sense of observation, you'll see two things. First of all, the hairstyle of the early 1990s. It was actually a hangover from the late 1960s, I think. And also that time has taken its toll on me as the years have gone by. But it's also a particular pleasure to be back in Australia in a meeting which is discussing the interface between global mental health, which is a discipline that's often seen as being about people who live in developing countries, alongside a discourse on the mental health of a subgroup of people in one of the world's richest countries, of course, indigenous peoples of Australia. And I hope that as we progress through this conference, that we will see that actually global mental health is about all of us in all countries of the world, because I don't believe there is any country in the world in which there is an inequality and disadvantage. But it's also very important for me to look back in time. It's quite a poignant moment actually for me to think back in time about my own journey in global mental health and where it began. And actually, it began here in Australia. Not only because I worked in Westmead Hospital as a psychiatrist and I saw inequality face to face in the early 90s in the western suburbs of Sydney, but also because I read and was profoundly influenced by the writings of a somewhat scruffy man, who some of you will notice scurrying in and out of this room. In fact, I remember reading this scruffy man's book way back in the early 90s when I borrowed it from the Strathfield Municipal Library in West Sydney, and was profoundly moved as a clinical psychiatrist. At that time I was a resident, about how this particular man was actually conceptualizing mental health in a way that actually I had never read or ever been exposed to in any of my training. So I think he actually takes a lot of the credit for the earliest inspiration I had in the work that I have been since doing over the last nearly 20 years. So what I'm hoping to do is to first of all really share with you a synthesis of how people in some of the poorest countries of the world are literally redefining and reframing what is meant by mental health care in order to address the so-called treatment gap. That is to say, the gap between the numbers of people in the population who have a mental health problem and could benefit from an intervention and who actually access those interventions. But then I want to carry on beyond this to think about, as I mentioned, the credibility gap, which I think is a far more provocative part of my talk and which I hope we can reflect on in some of the discussion. Now, just to introduce the core concern of global mental health, the field itself is only about a decade old. It's a child of the larger field of global health, which is primarily concerned with health inequalities and injustice in terms of the distribution of health resources in different parts of the world, as well as within populations, as well as the differences in health outcomes within and between populations. And the single most important focus of global mental health in this past decade or so has been on the issue of the treatment gap. And if we had to consider the evidence-based psychological and social interventions delivered in community-based settings for mental health problems, that treatment gap approaches 100% in most parts of the developing world. And by the developing world, I also include fairly wealthy members of the developing world, such as India. And of course, in Africa, it probably reaches 100% even for certain medical interventions like medicines for psychosis. So this is the primary concern of this discipline, and I think the innovators around the world have really had to address a number of very important barriers. Now, as you run your eyes down this list of barriers, I think some of you will begin to recognize that these barriers are not particular to developing countries. In fact, I'm sure many of you will see these barriers even in your own backyards in very well-resourced countries, such as in Australia. The first barrier, of course, is that in most parts of the world, and I'll return to this point, most people whom we call having a mental illness actually don't think they have a mental illness themselves. They often think about their problems in very different ways. Secondly, there is, of course, particularly true in developing countries, a number of competing health priorities, and Harvey's slide showed us that. For example, I don't know if you noticed in the heat chart that in South Africa, the number one, the reddest one, was HIV/AIDS. This is, of course, a particular problem of that part of the world. The third is very low political commitment, and I'll also return to this, just simply lack of interest in backing this particular area of health. Stigma is another very important issue, and I think fairly universal. And finally, and perhaps the most important barrier in terms of global mental health, has been the lack of skilled human resources. This is one of the strengths and the weaknesses of our field. We don't need complex technologies in what we do. What we need is a skilled human provider who can deliver interventions. And that is of great shortage in most parts of the world, particularly mental health professionals, and I'll return to that as well. Now, over the last decade and a bit, people in many different parts of the world have been attempting to address these barriers. And what I'm presenting to you now is really a high-level synthesis of how these barriers have been addressed, organized in a way in which I believe is reframing our notions of what mental health care is in three broad ways. First of all, what constitutes mental health care? Secondly, where is the care provided? And thirdly, who actually provides that care? Let me now start with what comprises the intervention. On this slide, there is the orthodox, more biomedical model. The orthodox biomedical model demands that we start by making a diagnosis. This is something which is also very integral, for example, to the World Health Organization's MHGAP model. This diagnosis is then followed by an algorithm, like a kind of a computer statement. If you have this condition, this then follows a set of treatment guidelines that follow automatically from that. This ignores completely actually what this diagnosis in fact means to the person who is affected or the community they belong to. There is a one-size-fits-all approach in this form of algorithmic approach. It doesn't take into account very often the contextual factors that are so central in understanding most mental health problems. And the interventions that you will see offered are essentially entirely biomedical. They're primarily comprising interventions that have been evaluated in randomized controlled trials. And I'll return to this topic in the evening when I will argue that actually some of the most effective interventions for mental illness in fact cannot be randomized. Nevertheless, when we look at guidelines in medicine, we privilege interventions that are randomizable. But in global mental health, what people are doing are changing our thoughts about what mental health interventions actually mean. First of all, we do not tend to use diagnostic labels, but instead tend to use labels that are actually friendly, not associated with shame, not associated with stigma. So for example, in the case of Zimbabwe, we use a label called fungisisa, which in the Shona language literally translates into thinking too much, which is a very well-described idiom associated with mood and anxiety disorders. We don't see the point of applying an ICD-10 label when no one understands what it means. We use contextually appropriate interventions, such as, of course, yoga, which is also, I believe, very contextually appropriate here in Cairns, but in fact, it actually comes from India and other parts of the Eastern tradition. And we use contextually adapted psychosocial interventions. We find, for example, the idea that human beings are autonomous beings may apply in certain cultures, but not in all. In fact, in most parts of the world, human beings live in family groups, and therefore the engagement of family members is a central element of many mental health interventions in many parts of the world. Secondly, where are these interventions provided? In the orthodox biomedical model, our patients have to come to see us. We sit nicely in some hospital building or in a clinic. But of course, for most parts of the world, psychiatric clinics are not very happy and nice places to go. They may look a bit like this. This is an image from a very disturbing documentary and a book produced by the award-winning South African photographer, Robin Hammond. I've put the URL at the bottom there. If any of you have the stomach to go to that video, you should look at it, because it gives you an insight into what psychiatric hospitals in sub-Saharan Africa look like today. These are actually images that he took on a long walkabout from Cape Town, heading northwards to a variety of different African countries which were affected by conflict. And he wanted to see who was left behind in the villages of these countries when people were displaced. Of course, the people who were left behind were like this man on the image, tied or chained to the walls of a mental hospital. When everyone decamped, the people they forgot to take with them were those who remained chained in those hospitals. This is not just a condition in Africa, but this is an image that was sent to me by colleagues from West Bengal in India of a mental hospital in my country. And what you can see here, of course, is something that's all too frequent in psychiatric institutions around the world. You can see a nurse walking menacingly towards a woman who's cowering, and you can see in her arm is not a therapeutic device. It's something that's about to be inflicted in an act of violence. This, of course, is a common and everyday experience of people in so-called hospitals for people with mental health problems in many, many parts of the world. So in this, I think another one I want to just remind you is this is not only about black and brown people. This is a particular hospital from Eastern Europe, which shows you the infamous cage bed that is used for people with intellectual disabilities who are having a variety of disruptive behaviors. Now the solution, of course, is not just a wholesale rethinking about what the role of an institution or a psychiatric facility is in these countries, but actually changing our notion of where mental health care should be provided. And these are the sorts of settings. In fact, these are the only settings in which we work in developing countries. And I think the most exciting setting that you will see is right at the bottom, actually delivering care where people live rather than where doctors live. The third is the issue of who provides these interventions. Now, again, in the orthodox and biomedical model, this is mental health professionals who've had extremely high levels of training, and no doubt these are also associated with very high levels of skills. The problem really is that there aren't enough of them. There aren't only enough of them, but they're also very inequitably distributed. Let me give you an example from two countries that I know very well. India has a population of over 1 billion people now. Now, I also work in Britain, which is comparatively a much better resource country. If I had to take the ratio of the number of psychiatrists to the population in Britain and apply that to the population in India, I would expect about 150,000 psychiatrists in India. The true number, of course, is a minuscule fraction of that number. There are fewer psychiatrists, I think, in India than there are probably in Australia. I don't know how many there are in Australia, but certainly a whole lot fewer in India than there are in Britain. In fact, I often jokingly, but sometimes sadly, remark there are more Indian psychiatrists working in Britain than there are in India. And I think this is a reminder to us that any model of mental health care that predicates delivery by highly trained mental health professionals is not going to work in most parts of the world. And certainly when I travel around rural and remote regions of rich countries, I say the same thing applies just as well to those countries. This is not a peculiarly developing country problem. The other thing to remember is that even this small number doesn't actually reflect an available number, because about half of these professionals live and work only in urban areas, where only a minority of the population actually lives. So what's the solution that global mental health innovators have used? They've used what's called task sharing. Essentially, instead of asking for more mental health professionals and waiting for what could be decades of waiting, we are looking around us and seeing who do we have who's available in our communities, who can perform the role of being a mental health provider. And of course, there's plenty of such people in every community of the world. Here are 3 examples of randomized controlled trials, that very important kind of study design that medicine places a lot of emphasis on, which have evaluated the delivery of evidence-based psychological and social interventions for people with depression and anxiety disorders in 3 very different parts of the world. The first trial was using interpersonal therapy delivered by lay health workers in rural Uganda. The second trial was by using community-based maternal health workers, who are essentially ordinary people, women from the community, who have been given additional responsibilities for mother and child care, delivering CBT, maternal depression. And the third trial is my own trial from India, which is looking at a low-intensity collaborative case management for depression and anxiety disorders in primary healthcare settings. All 3 trials have produced important results demonstrating the effectiveness of using lay people to deliver psychological and social interventions for mood and anxiety disorders. In fact, this has been one of the most exciting areas of global mental health. And recently, my PhD student Nadia Van Ginneken carried out a Cochrane review examining really what the strength of the evidence base was beyond these individual studies. And much to her surprise, she found that there was a hell of a lot going on in the field in terms of controlled evaluations of these models of healthcare. 17 randomized controlled trials, that's not a small number in global health. And another 11 non-randomized controlled studies coming from a variety of low and middle income countries in the world, and using a variety of different healthcare providers. So as you can see here, a number of different sorts of non-specialist health workers have been evaluated in terms of delivery of interventions. But perhaps the single biggest number is the lay health worker. 22 of these comparisons involved lay health workers. Lay health workers, as I mentioned earlier, are ordinary members of the community who are provided with specific competency-based skills to deliver interventions such as CBT. They go beyond just psychological treatments, though. These are some of the roles that these non-specialist workers play, and I'll be showing you a short video that really illustrates this from a program of ours in India. They provide education and information to the patient and family. They provide much needed support to family members who are often struggling to try and understand what is going on in their loved person's life. They provide support for continuing treatment. Many of these individuals do need to take either continuing care in the form of medicines or psychological treatments, and they need support with that adherence. They perform very central roles of just being a friend, just carrying out ordinary, non-specialist befriending interventions. For example, going down for a walk in the park with someone who probably hasn't done that for a long time. They provide early skills for early detection of an impending relapse and appropriate referral in time. They promote healthy lifestyles and behaviors, such as, for example, healthy eating and behaviors to do with reduced smoking and other substance use. And of course, they also provide specific psychological treatments. And it's the last which I think has been one of the most exciting areas, training ordinary people to deliver treatments that many of us have spent a fairly long time in our lives learning how to deliver. And this is what the result is of doing that. Those of you who understand forest plots will immediately follow this slide, but for those of you who don't, what I really want to just focus on is the box which is in, the numbers which is in a red box. And what this tells you is that essentially, amongst those individuals who received a psychological treatment for depression delivered by a lay health worker, there was a 70%, the 0.3 simply means a 70% reduction in the risk of depression and follow-up compared to those individuals in the comparison arm who received usual care, showing to you the very large treatment effects of a lay health worker delivered psychological treatment. Now, it's important to point out that these lay health workers or non-specialist workers aren't working alone. It's extremely important to remember that all community health worker models are really built around the idea of collaborative care, and this essentially means a partnership. All mental health care, and indeed all chronic disease care, is fundamentally a partnership between 4 key players, as shown on this slide. And I want to particularly highlight, of course, the role of the person with the mental illness and his or her family as a key and equal member of that particular process. Now, I want to move on to looking at what the impact of this sort of evidence base. I've really given you a whirlwind view of really what is a fairly large evidence base in global mental health. And I want to just now look at some of the impacts that this evidence base is having on our field in terms of improving access to care in developing countries. And I want to start firstly by showing you a 2-minute video of a program it was again a randomized control trial which was published in The Lancet, which looked at using this collaborative care model in which you had a non-specialist community-based worker to work with people with chronic schizophrenia. The average duration of illness of people in our study was about 12 years, and a substantial number of them had not had any active treatment in the past year and were severely disabled by the illness. So I'm just going to show you a short video that gives you an idea of the roles of different people in that program and the experience of a couple of participants. If I could ask you to please turn the video on.
सो एकदमच मला कम से कम एक 5 मिनिटं आवाज माझ्या कानाला मी देव बोलतोय असं.
मानसिक आजार हे काय असतं हे मला याच्याबद्दल काहीच माहिती नव्हतं. म्हणजे हा प्रकारच माहित नाही. मला काहीतरी म्हणजे समायोजित वर्तनात काहीतरी आहे असं मला सारखं वाटायचं. पण कोणापुढे बोलायचं हा एक माझ्या मनामध्ये कुचंबणा व्हायचं.
आजूबाजूची लोक ते दृष्टिकोनात बघायचे तिच्या येडीचे हसती बघा कशी. कोण माणूस पुन्हा येणारा असला तरी त्याला असं वाटायचं ती माझ्याकडेच बघत हसली म्हणून तो माणूस असा बघत उभा राहायचा. मग मी ते उभे राहायचे. मी 2-3 माणसांना बडावलं बी त्याच्यात.
वाईट वाटायला लागलं की झाडाला धरायचं रडायचं. कुणाला सांगायचं नाही पण असं आहे म्हणून.
तसं तर देव वगैरे केलं लाग भांगेल ले केल्या बरं का. जेव्हा ह्या देवा जात त्या देवा जात त्या उडक्याला पळा कुठे पळा लांब लांब लेप जो 5-6 महिना राखवणं देवासाठी अप्रमाण उलट देवा वगैरे जास्त वाढायचं तर कमी नाही.
कॉप्सी हा प्रकल्प जो आहे तो त्याचा लॉंग फॉर्म असा आहे केअर ऑफ पीपल सिझोफ्रेनिया इन इंडिया. म्हणजे औषध उपचाराव्यतिरिक्त जर काही सामाजिक उपचार पद्धती जर या लोकांना चालू केली.
डॉक्टर आणि पेशंटच्या मधला दुवा असा आमचा रोल होता.
म्हणलं पाठवा की शिक्षण बरोबर, कारण आम्हाला माहिती येते कसं काय गोळ्या घ्यायच्या, कसं काय करायचं किंवा काय करायचं, कसं त्याच्याशी वागायचं, कसं काय म्हणलं आम्हाला माहिती मिळेल.
हे तुम्ही जे प्रोग्राम हे ठेवलं होतं ना, हां, तर त्याचा पुरेपूर फायदा आम्हाला झाला. म्हणजे औषधांचं तर झालंच, पण औषधांपेक्षा पण ते जास्त म्हणजे संभाषणाने यांच्याशी व्हायचं ना, बोलायच्या.
जोपर्यंत जमेल ना तोपर्यंत तरी काम असावं आपल्याला, असं वाटतं. जोपर्यंत जमेल तोपर्यंत. दिवसभर म्हणजे काही विचार वगैरे काही येत नाही, दिवसभर याच्यातच मन रमतं ना.
आता जरा बरं, आधीपेक्षा बरं. कामाला पण जाते, त्यामुळं शाळेत आधी शाळेचा खर्च आधी नव्हता, पण आता खर्च आले ते मम्मी घालते.
Work is not just for money, it is for self-esteem. It's what you think about yourself. It's the way you spend your time. It's your productivity. It's what you give to society, what you get from society. So when they start working, then they feel much better. People learn to respect them. They start liking themselves.
आत्ताची परिस्थिती आणि त्या टायमाच्या परिस्थितीमध्ये किती आसमानचा फरक. म्हणजे माझं कारण म्हणतंय इथून पुढं जे तुम्ही चितलेलं काम आहे, म्हणजे जे माइंडमध्ये तुम्ही ठरवलेलं पुढं लय त्याचं चालना मिळणार.
So I just want to say that, you can take it, thank you. I just wanted to say that the lady that you saw speaking in English is Dr. Tara, who is one of India's leading psychiatrists who works in the area of working with people with schizophrenia. So that was just to give you a very brief snapshot of really some of the experiences within the scope of a 2-minute talk. But I also wanted to share these narratives of the impact that doing this kind of work has on people who are delivering care. I'm not going to read the narratives, you can look at them on the slides, but as you read these narratives, you will begin to see how empowering it is actually for ordinary people to become involved in mental health care. And fundamentally to me, this also demonstrates the power of democratizing the knowledge that we carry by sharing it with other people, and what an empowering experience that is, not only for those who receive the intervention, but also importantly for those who in fact provide the intervention. There's also been a very important impact on research programming around the world. Some of you will be familiar with the NIMH's Grand Challenges in Global Mental Health that was published in 2011 in Nature. I was the co-chair of the Scientific Advisory Board, and what we did was we really asked more than 400 stakeholders around the world to tell us what they thought were the leading challenges that needed to be addressed if we were to reduce the burden of mental disorders in the way that Harvey described. And as you can see, these are the 5 leading challenges. What's really interesting about these leading challenges is that none of them are talking about discovering a new brain circuit or about a new molecule. In fact, they're all talking about doing better, delivering better what we know works. It's really bridging the no-do gap. They're all about implementation questions, and my colleague Rahul, who will follow, will be talking a little bit more about that. Since then, there has been a lot of funding that's gone into supporting this research agenda, such as 5 hubs for international mental health research supported by the NIMH, a substantial program of work and research being supported by the Canadian government through Grand Challenges Canada. It's very unfortunate I don't have any information from Australia, but maybe Helen, you might share with us what the Australian government is doing to support global mental health. But certainly many wealthy countries in the West are doing a lot, and I think this is something which is happening in response to the Grand Challenges publication. An important resource that some of you may want to look at, which will give you a lot more details about the sorts of innovations I've only briefly described today, can be found on this website, the Mental Health Innovation Network. You can see the web link there. This is a platform that's been set up by my colleagues and myself at the London School of Hygiene and Tropical Medicine, which is really seeking to provide a kind of a go-to place for people who want to learn more about these innovations and also to submit innovations of your own. And this is truly global. It is not only about developing countries. Many of the innovations you will see on our website are actually coming from wealthy countries where innovators are trying to address mental health inequalities in their own backyard. There's also been tremendous impact on policy. As Helen mentioned, I've served with the Government of India's Mental Health Policy Group for the last 4 years. And we produced India's first national mental health policy in October 10th last year, launched by the Minister of Health. And importantly, if you look at this policy, you will see many of the principles that I've described, for example, home-based care, care by non-specialist workers, and redefining the content of care, fully integrated within the content of this policy. In doing so, friends, what I want to suggest to you that what global mental health innovators are doing is actually suggesting a paradigm shift in how we think about mental health care. By deprofessionalizing some components of the care and taking it to the community, we can shift our discourse from constantly whining about what we don't have, which is highly expensive and unaffordable specialists, to start thinking about how we use what we have in a more efficient way, including our specialists, but importantly also including other people in the community who have historically simply not been considered as part of the mental health care system. In doing so, I believe we can rethink of every society as not being under-resourced, but as being richly resourced. I want to now finish off by looking ahead and thinking about a more provocative area, which is the issue of the credibility gap. I want to suggest to you that it's not simply a question of supply problems that is an important issue in mental health care around the world. Because even in countries like Britain, which have, in comparison to India, an almost picture-perfect healthcare system, although the last election results might change that in years to come, but nevertheless, at least right now, we still have a very, very good healthcare system in Britain. The fact remains that there are very large proportions of people, even in these universal healthcare systems, who have no access or do not seek care for mental disorders. This is from the World Mental Health Surveys, which tells you the contact that people with moderate to severe depression and anxiety have had in the last year with any healthcare provider. And I want you to really look at the figures at the bottom of the slide, because those are from rich European countries, mostly European countries, which have a social insurance provided healthcare system. So there's no cost of care. There's lots of mental health providers. Care is provided through a robust primary care system, and yet 50% of people with moderate to severe anxiety have had no contact with any healthcare provider, and only about 12 to 15% will have had contact with a mental health care provider. There's also a worryingly low response of all this evidence base on the sorts of actions that Western agencies, which fund development assistance for health, are having on mental health. Here you can see the impact of the evidence base on actual allocations that are made for mental health funding for the developing world. This is from rich country development agencies. And you can see that even after all this evidence, it's still less than 1% of the total development assistance in health. I believe that all of these are reflections really of what I call a credibility gap. And this is a gap, more fundamental one, between the biomedical construction of mental disorder, which people like myself have traditionally used, characterized by diagnostic systems, the epidemiological instruments and treatment paradigms, which actually differ quite substantially from how the rest of the world around us tends to conceptualize psychological suffering. I want to give you some examples of that. The first is the medicalization of normative emotional responses, leading to incredible numbers of people being diagnosed. In many surveys, they lead to figures that many people find simply incredulous. The use of very complex jargon terms. I found that discourse on DSM-5 when it was released last year was a good example. Even the founders of DSM-3 and 4 were contesting DSM-5. This is how much of a lack of actual credibility we have developed in all the diagnostic labels we've created. And then always thinking of biomedical solutions for mental health problems and not looking at other solutions beyond the narrow clinical confines. I've thought hard about why my colleagues in psychiatry and clinical psychology, particularly psychiatry, it has to be said, have really constructed this whole edifice that seems to be more and more disconnected from the discourse on mental health in our communities. And I think it's because of a genuine desire that we have to become part of medicine, to be respected by our colleagues in medicine, and therefore to start using systems that approach the physical medical model. And to do that, what we have to do is to develop diagnostic systems and tools that can be applied in the same way across cultures. We need to standardize our interventions so they become one size fits all, so that whether or not you have malaria in China, Congo, or India, you still use the same medicines. We would like to think that we would use exactly the same approach for depression and schizophrenia. But I think there is a fundamental problem here. And the problem is that there is no resonance or similarity between having malaria and having depression. There is really no similarity between having a boil on your back and feeling miserable because your husband died. There isn't really any similarity between having a blood test telling you your blood sugar is high and hearing a voice that tells you that your neighbor is spying on you. I think the fundamental difference in my mind is that the physical experience is clearly separable in most people's minds from themselves, whereas the mental health experience is completely embedded with one's understanding of who one is and the social world that one lives in. In fact, I often think as a psychiatrist, why did I choose psychiatry in the first place? It seemed to me it was precisely because of this reason, that there was such a close interface between one's health experience and one's social world that made psychiatry the most human, the most socially sensitive of all the medical sciences. And it seems, in my mind, a bit of a shame that we seem to have moved away from that mooring in society. In fact, it seemed to me psychiatry was the perfect blend of medicine and society. I want to finish by 3 ways in which I think we can address this credibility gap. The first is I think we need to be a bit more upfront with distinguishing mental disorder from psychological distress. I think, as Harvey showed us, about 2/3 of the burden of depression and anxiety, which in itself is about half of the total burden of mental disorders, is mild conditions. And if you look at the treatment guidelines for mild conditions, it's often just giving the kind of low-intensity psychosocial support that I mentioned earlier. Do we really have to call these people suffering from a disorder? Is it possible that we can begin to use less stigmatizing diagnostic labels? And interestingly enough, even though this particular idea comes from the left field of mental health, interestingly, it's actually very consistent with the right field, the stuff that comes from neuroscience. And here I show you a very important paper that comes from Pat McGorry's group that actually makes exactly the same argument, but approaches the same issue from a neuroscience basis. So what they argue is that if you look at people with mild distress states, they don't use the word disorder. What they really think about is these are distress states in which you have mixed emotional and behavioral symptoms, often linked quite profoundly to people's social circumstances. And only a smaller group of individuals go on to have disorders. For those who have distress states, I would suggest that we emphasize non-biomedical procedures or interventions on platforms for care, and such as the interventions that I think many of you will be familiar with and which I've already described earlier, including promoting self-help, both through, for example, the internet as well as through books. And finally, for those who actually have frank disorders, and here I limit myself primarily to psychological interventions, some of the more exciting work that is happening now is to move away from diagnosis of disorder-specific packages of psychological treatments, but instead to start looking at transdiagnostic interventions that are addressing some of the common psychological processes, like, for example, poor problem-solving skills, poor anger management skills, poor anxiety management processes that are actually common across many different diagnostic categories. And we now have some tantalizing evidence that demonstrates not only that this is possible, but in fact that it's also effective. This is my last slide. I want to end by simply saying that I hope that in my talk what I've suggested to you is 2 important lessons that we are deriving from work that has happened in the developing world, principally around improving access to care, which is to support the development of community-based teams and organized collaborative care which is led from the front line by people with mental health problems and non-specialist community-based workers with support by the specialist. And secondly, to acknowledge and champion the differences between mental health care and physical health care as a way that we should ultimately use to bridge the credibility gap between the mental health worldview and the worldview of mental illness as held by the communities around us. Thank you very much.